Hello, my name is Nikon Sharifabadi. I'm a student physical therapist from the University of St. Augustine for Health Sciences in San Marcos, California, and I'm going to present to you a case on chronic low back pain. According to Rundle et al. From the Journal of Physical Therapy in 2018, low back pain is the most common work-disabling injury in the United States and affects about 80% of our population. The purpose of this presentation is to explain to you some of the impairments that may result from low back-related injury, link those to how they may affect the daily function, and finally discuss evidence-informed treatment plan for each of the impairments that were found during the evaluation. So my patient is a 63-year-old man, mesomorphic build, right-hand dominant, retired engineer. His chief complaint is stiffness in the lumbar spine, dull ache in the right lumbar region, and occasionally a crippling flare-up from the right lumbar spine to the right gluteal region, down to the posterior thigh and lateral leg. He claims these symptoms arose after a long day of digging holes in the backyard to plant some trees while doing repetitive bending, twisting, and lifting motions about 17 years ago. My patient claims that the flare-ups occur when he's overworked and leaves no time for rest, which he does his best to avoid. He has gone to a variety of rehabilitation approaches such as chiropractic and acupuncture therapy, used over-the-counter medicine to alleviate his constant pain, but none of these have had any long-term success. He's seen his primary care physician but was never diagnosed to his knowledge and is sent to conservative management, which he claims was a few sessions of physical therapy, but the only thing that really relieved his symptoms are just resting. The numerical pain rating scale was used to quantify my patient's pain. The NRPS ranged from 0 to having no pain and 10 having the worst imaginable pain. Currently, he's at a 3, at best a 0, and at worst an 8. Things that made his pain worse were overexertion of activities such as gardening or anything that caused his trunk to fatigue. The only thing that made his pain better was rest and laying in bed. According to Algier et al., the Journal of Pain and Research in 2018, the NRPS had an excellent inter-rater reliability and validity. For this scale, we'll be looking for a 2-point change in the minimum clinically important difference. The medications he is taking are aspirin, statins for cholesterol, medications for his prostate, and blood pressure medication, which is well controlled. His prior level of function consisted of 2 to 3 hours of constant yard work without any fatigue, walking the dog around the neighborhood with no pain at all. His goal is to improve tolerance to exercise, to continue his hobby of gardening with no pain or range of motion deficits, and reduce low back pain and the occurrence of the flare-ups. So I use the Oswestry Low Back Pain Disability Questionnaire as its outcome measure. Is a patient-completed questionnaire that gives a subjective percentage score of the level of function of specific activities of daily living for people who are rehabilitating for low back pain. The scale is 0 to 5 on each section, with lower scores indicating no disability and higher being bedridden and fully disabled. My patient scored at a 26, which falls under moderate disability currently, and during his intense flare-ups, he has scores about a 74%, which happens maybe a few times a year, which falls under crippled. During his more common flare-ups, he scored at 54%, which is severely disabled. According to Mikasic et al. From the Spine Journal, Philadelphia in 2013, this outcome measure has excellent test-retest reliability and validity with a 12.8 change in score for a minimal clinically important difference. So structurally, my patient presents with rounded shoulders and neutral pelvis in standing and with right iliac crest inferior to the left and sits in a posterior pelvic tilt. His active range of motion was limited in flexion at about 60% as he deviated to the right and then pain comes about. Left side bending and right rotation were also limited at about 50%. His extension was limited but mainly due to poor motor control. Right side bending and left rotation were within normal limits, and he complained about stiffness in all these motions. For muscle palpation, we did reveal some increased tone in the bilateral paraspinal muscles and limited musculature in the gluteal region. Excess adipose tissue in the abdominal region was also noted. When conducting a passive range segmental mobility test, I found a few hypomobile segments and a hypermobile segment. Hypomobility was found at the right L4-5 segment and L5-S1 segment on the right side with a grade of 2. As for the hypermobility, it was L3-4 segment and it was graded a 4. The neurovascular screen was noted to be unremarkable with the exception of bilateral hip flexor weakness, both receiving a grade of 3+ out of 5. The lower quarter screen assessment revealed that there was some tightness in bilateral hamstrings and weakness in bilateral hip flexors as previously stated. No diagnostic testing was performed at this time. We did a few special tests to rule in or rule out any possibilities or contributing factors. The straight leg raise was done in a supine position with the testing lower extremity knee extended. Lower extremity leg was passively raised into hip flexion to assess neurological tissues and their sensitivity to mechanical stress. Symptoms came about in the testing leg at 48 degrees, which might suggest a possible disc herniation onto the L4 to S1 nerve roots or other neural implications. Slump test was also done by slowly, progressively taking the patient through neural tensioning to assess the neural tension sensitivity. In this case, reproduced our patient's symptoms. The patient was seated with his legs off the table and at the edge of the table, and in a slump posture with overpressure into cervical flexion and thoracic extension. The lower extremity was then flexed at the hip while keeping the knee extended, followed by ankle dorsiflexion. And in our case, the symptom came about right when the dorsiflexion came, and he was directed to flex his knee and the symptoms resolved, thus indicating a positive test. Supine to sit was done to assess whether the structural observation at asymmetrical iliac crest was due to a structural leg length or a functional leg length inequality. The patient was in a supine position where the legs were flexed, and then we brought his knees to his chest and neutralized the pelvis and the lumbar spine. Then assessed his legs in extension side by side. Then we would follow up with the patient sitting up in the long seated position and then assess the legs again. In this case, the leg was longer in sitting and shorter in supine, thus resulting in a posterior torsion of the right ilium on the sacrum. All other sacroiliac joint tests were unremarkable. We did a movement analysis to assess the mechanics, and you noted that initial contact of the right lower extremity, the patient had pain, and then he had shorter stride length bilaterally. The patient also exhibited pain with forward flexion at the hips and then knees into chest and supine. The PT diagnosis using the International Classification for Function was that we would classify this patient with low back pain with mobility deficits and chronic low back pain with radiating pain. The PT long-term goal was that in 4 weeks, the patient will restore full range of motion and improve strength in the local muscle stabilizers in order to carry out desired activity of gardening with 0 to 10 pain for an extended period of time. As for the impairments, first I would like to look at the hypomobility at the L4-5 and L5-S1. We would be doing a posterior antero grade 3 mobilization. Shum et al. In 2013 from the American Conference of Rehab Medicine concluded that there's immediate effects of this mobilization on reducing back pain, stiffness, and range of motion of the lumbar spine. We could also add doing a positional distraction on left sideline without any rotation during the flare-ups to help open up any of the facets or just alleviate any of the symptoms on the right side. Next, I'd like to look at the hypermobility of the L3-4 segment by doing a motor control strengthening activities. Koss et al. Did a study with motor control exercises of the multifidus and transverse abdominis strengthening versus non-therapeutic modalities, and there were significant improvements in favor of the motor control group for activity tolerance and global impression. Next, I would like to look at the posterior torsion of the right ilium on the sacrum by doing low amplitude, high velocity manipulations of anterior torsion of that hip. So Gong et al. In 2011 for the Journal of Physical Therapy Science performed prone manipulation that I stated above with people with at least a 10 millimeter functional leg length inequality and performed the manipulation for 12 weeks, 3 times a week, saw about a 9 millimeter improvement on average of the experimental group. Next, I'd like to look at bilateral hamstring tightness by doing hamstring stretches of the antagonist hold. And the Lee et al. In 2017 of the Journal of Physical Therapy concluded a study with patients of low back pain. Doing these kind of stretches had significant difference in pain level and pain threshold, and then a disorder index of low back pain decrease as well. Next, I'd like to look at a nerve mobilization and improving the tolerance by doing some neural tensioning of the lower extremity. Cleland et al. Of the Journal of Manual Therapy in 2016 completed a study with patients with low back pain that had symptoms distal to the buttocks and reproducible symptoms in the slump. Did slump stretching with exercise, and in about 6 sessions, these people had reduced disability and reduced overall perception of pain. Next, I would like to look at the hypertonic paraspinals and do soft tissue work and trigger point treatment to help reduce that. Next, I would be looking at the one joint hip flexors that were weak, and I would target those by doing standing marches and progressing to weighted marches with like ankle weights. Finally, I would do patient education to educate the patient on the importance of an active lifestyle incorporating progressive low-intensity, sub-maximal fitness and endurance activities, and postural awareness, of course. The prognosis for my patient would be poor for his rehabilitation. He's a 63-year-old male with a 43-year smoking career, sedentary lifestyle, slightly overweight, and he has a low motivation for rehab. To summarize, the patient's body has created a mechanism to prevent further tissue damage by preventing motion at the lower segments due to a possible chronic disc injury, therefore making up the motion at the segments above. These symptoms of my patient are aggravated with increased repetitive activity, thus benefiting from improved tolerance of the spine's local musculature to stabilize during all activities. Chronic low back pain comes in a variety of diagnoses and symptoms, thus important for all physical therapists to be able to pull out from the impairments found during an evaluation and get to the root of the problem, as low back pain patients will be very common. This is an example of how to develop an evidence-based program based on the individual's impairments and patient's goal. Thank you for listening to my presentation, and I'll take some time to answer any questions you may have.